So without further ado, of course, to my right, to your left, Dr. Cheng, urologist here in St. Thomas. Just, for your knowledge, when we did first talk about this month and how important it was, and when we did start advertising and promoting this event, I can't tell you how many positive comments we had and how many people appreciated your patient services over the last couple of decades here in St. Thomas. So I just wanted to tell you that. I think a lot of people are tuning in today and appreciative of everything you've done for them and continue to do. So a lot of positive response.
It's been a pleasure working here for the last 21 years or so. I really enjoyed it. My family enjoyed that too.
Oh, that's great. Yes, 21 years here in St. Thomas, 28 in total in practice. So welcome. Thank you so much for being here. We know you're a busy man. Let's just dive right in. There's a lot of people joining us today. Our biggest RSVP that we've had so far. So I think there's over 50 people on the other side of the computer joining us. So I think we should just jump right in kind of from the beginning about signs and symptoms. What should a person be looking for?
The problem with prostate cancer is that often there are no symptoms, and we pick them up early as a result of blood tests, screening blood tests. Pick some of them up as a result of family history. In the past, in terms of family history, it used to be the older generation getting prostate cancer and then the younger generation getting screened. But people are getting older, so now we've seen younger people getting, the sons getting prostate cancer, and then we screen the father and we find prostate cancer in it. But by and large, there are no symptoms. Most men that we pick up with prostate cancer have no symptoms. If there are symptoms, some of the ones are your typical, what we would consider aging urinary symptoms, slow stream, frequent urination, getting up too frequently at night. But most of these are due to just enlargement of prostate, not prostate cancer. Other things like blood in the semen, no ejaculate, those are rare. And again, most of those are not due to prostate cancer when you go and investigate them. And then the other late signs are bone pain and kidney failure. Those are very late disease.
Mm-hmm. Now, we were talking off camera a little bit earlier, and it's about 1 in 8 men who are diagnosed. But when we really break those numbers down, what are you seeing? Well,
when you look at it, it's approximately 1 in 8. But realistically, if you biopsy everybody and you look at autopsy studies, it's a lot higher number. By the time you get to 70, 80 years old, it's 1 in 2 will have some sort of evidence of prostate cancer when you look at their prostate, but not every one of those need to be diagnosed, and not every one of those that are diagnosed need to be treated. Okay. So again, it's most of prostate cancer is an indolent disease that over time people die with it, not from it. So yeah, it's an alarming number of people will have it. But again, not everyone is needed, and it is a disease of the older population, but it can be in younger people. I've recently diagnosed somebody who's 36.
Wow!
And again, incidental finding is when he did have urinary symptoms, but when we scraped the prostate, it was cancer. But anecdotally, when we biopsied the prostate, there was no cancer. So, most of the ones that I pick up are in their late 50s or 60s and then beyond. It's rare to find them under 15.
So you say people die, men tend to die with it and not from it. Are there any preventative steps they can take?
Yeah, unfortunately, there's no prostate healthy diet or prostate healthy activity. In general, there's just a healthy lifestyle and healthy diet, and lots of fruits, lots of vegetables. Keep yourself hydrated. There is not one thing that you can do to prevent prostate cancer. But having said that, the only thing that can prevent prostate cancer is if you have low testosterone right from a young age. And you're not going to suppress somebody from any man from producing testosterone just to prevent prostate cancer, because that's a vital hormone for your growth.
Let's go back to the younger diagnosis that had just happened, 36 years old. The reaction to that, it's probably very shocking.
It's shocking for him, for the family, and it becomes something that is held over him for the rest of his life, right? He knows that this is there, and we have to just keep monitoring it. But hopefully, as time goes on, things remain quiescent, and it will not be as nervous, as anxious.
Sure. And speaking of age, when should men be screened?
Yeah, that's very controversial. Earlier in my career, there was a recommendation from both the Canadian Urology and American Urology that about 50 men should be screened from 50 to 70 with rectal examinations and with a blood test PSA, prostate-specific antigen. As time went on, that recommendation has been nixed, and now it just becomes as a conversation that you have with your family doctor or with your urologist as to if and when you should be screened. I don't tend to screen everybody. What I do is, again, if they come with a family history, if they get sent to me for other reasons, I tend to do a PSA and do a rectal examination as a baseline, just for future reference. But otherwise, I think that it really becomes a conversation as to between an individual and their family doctor and with their urologist. But I don't have a right answer for that.
Sure.
Yeah, but typically, if you want to get screened, it would be about 50. And if you're older and you're starting to have urinary symptoms, then definitely.
Yeah, that was a little bit of my follow-up question. Are there any circumstances where an individual would seek that out earlier, or based on genetics, anything like that?
Yeah. If somebody has a family history, I certainly would recommend that they get checked starting at age 40, at least a baseline PSA and a rectal examination, and then depending on the level, depending on the other symptoms, maybe once a year, once every other year, get the PSA and the rectal examinations checked.
Yeah.
And then the other, I forgot to mention, one of the things that we know is that there is some propensity for Black people to have prostate cancer at earlier age, and also a more aggressive or higher grade. So when there was a recommendation for screening, the recommendation at that time was to screen people of African descent earlier and to screen them more frequently. So that population, I tend to keep a closer eye on as well when they get referred to me.
Sure. Yeah, I mean, the risk, like you say, it could be different among different subsets. But can you continue to unpack that a little bit more for us in terms of risk and age, correlation there, and so on?
Yeah, well certainly the risk. Some of the risks are, one is if you have a family history, and it tends to be more paternal side, so like a paternal uncle, like your father, paternal uncle, a brother. Those are put you at higher risk. And then certainly as you age, the incidence of picking up prostate cancer becomes higher. So yeah, when somebody older nowadays, maybe 70 or 80, they come with urinary symptoms or other urology problems, rectal examination, and I'll send PSA out.
Yeah. So what I'm hearing is that encourage people to have those tough conversations,
Absolutely.
perhaps Thanksgiving, of course, around the corner.
Yeah.
Maybe that's a chance.
Yeah.
Rip the Band-Aid off and let's talk about it.
Yeah, absolutely. I mean, I think what's important is also know your family history. You know, I hear a lot of men that tell me that their father died of bone cancer, but they don't know where the primary is from. It could have been from prostate. So it's important to know a bit about the family history. This way we can kind of evaluate what your risks are and whether or not to investigate more.
Mm-hmm. Yeah, very important. So with, again, Thanksgiving around the corner, having those difficult, candid conversations with your family is very important.
Yeah, and then, you know, it works both ways, right? If you find out that, somebody has, that there's risk of prostate cancer, then you be a little more concerned and probably screening more frequently and maybe have a lower threshold to send you for a prostate biopsy, which would be pretty uncomfortable. But if you find out that no, they just have prostate problems that got treated for urinary problems, but there was no cancer, then that would change the approach, and the threshold to biopsy somebody like that would be higher if they have urinary problems. More likely just to treat the urinary problems.
Yeah, and you know what, Dr. Cheng, you're throwing out a ton of digestible, great information, and we do want to just remind you at home or in your office, wherever you're joining us from, that we will be posting this entire segment to our YouTube channel, on our STEGH Foundation YouTube channel. So don't worry if you need to, pick up the grandkids or get your kids off the bus, whatnot. We will be posting this after, so not to worry.
So you did talk about, one of the things I keep mentioning is the PSA, which is the prostate specific antigen. I want to clarify that test is a test that we use to screen and to help us evaluate the risk of prostate cancer. It's by no means a diagnostic test for prostate cancer. Most people who have a PSA that we think is not appropriate for their age or higher than what we would expect for their age. Most people with those higher PSAs do not have prostate cancer. So when somebody comes, often they get referred to me because of a high PSA. We need to look at the actual number, and there's many other parameters that we look at to determine whether or not you need to take that next step to biopsy. So a high PSA by itself is not necessarily prostate cancer, and a low PSA by itself does not guarantee that there is no prostate cancer.
Okay. Yeah. Is there, flipping that to the other side of the point about the treatment process and what people should expect, or how it's treated from start to finish, or if there is continuous care. How can you unpack that treatment piece for us?
Yeah, treatment, it depends. Once somebody is diagnosed with prostate cancer, you need to determine whether or not it has spread, and then you also want to see what the risks are. We break the risk of the cancer into low risk, intermediate risk, and high risk, depending on their age, their PSA, the grading of their cancer, the number of positive cores in the cancer. So there are multiple variables that you look at, and people that are deemed low risk, you can really just watch them, monitor them with their PSAs with rectal examinations on a regular basis. And if there's a change and any concern, then you can proceed with a biopsy. People with what we would consider intermediate risk, most of those are going to need treatment unless they have other health issues that would kind of rule them out or prevent them from having treatment. And some of the intermediate risk, depending again on age and other medical conditions, we can watch them. People with high risk definitely will need treatment, and often some of the high risk ones will have metastatic or disease where the disease has spread beyond the prostate, and the treatment could be different. So our treatment that could be surveillance, and active treatment could be radiation or removal of the prostate. And then there's palliative treatment, which is hormones, chemotherapy.
Yeah, and I can only imagine that this is quite terrifying for a lot of people who you see. Talk to me a little bit about that, because obviously a lot of our viewers are tuned in to hear about that from you.
Yeah, it's never a pleasant task to inform somebody that they have prostate cancer. And I think that most people, when they hear prostate cancer, they don't hear the prostate part, they try to hear the cancer part, and that is extremely unsettling. But what I emphasize to them is that it is cancer. We need to determine how best to manage this. Not every prostate cancer needs treatment, and we have to determine what the risks are. And then it's important for me to emphasize to them that there are treatments available. The treatments may not be curative, they may be surveillance, they may be palliative, where you're trying to manage them so that they can live with the disease. So there are options, there's treatment. So having the diagnosis doesn't mean the end of the road. And then I also emphasize that most men die with the prostate cancer, not from prostate cancer. So despite the fact that it's unsettling, you have to kind of put things in context compared to other types of cancer.
Would you say that if somebody watching is take away one nugget of information, it would be that you're not potentially going to die from it, you're going to die with it?
Yeah.
So there is longevity.
Yeah, and there are treatment, and that there are treatment options available. That this is not, sorry, you got prostate cancer. That's what you're going to die from that.
Yeah. What about the physical, the mental, the emotional sides? Because I can only imagine, again, hearing that diagnosis and then mentally digesting all of that.
Yeah.
What is that like?
Again, it's stressful to get the diagnosis, but then once you need treatment, people become stressed by what the potential side effects of treatment are, and some of the side effects are erectile dysfunction and urinary incontinence. So those things just pile on top of the stress that they have, and then some of the treatments can cause erectile dysfunction. And so emotionally, that's extremely trying on them and their partner. Mm-hmm. And physically, the treatments can be fatigued. And we talked about the incontinence, and that can make it difficult for them to go out. And some of the treatments can cause the bones to be weaker, and so they risk fracturing. So in those instances, it's also very important that they remain active, mm-hmm. so that they can keep their bones strong. So no matter what, sorry, I'm going to just go back when you
said what. Please do. The floor is yours.
When you talk about prevention, nothing you can prevent, but it's important for this, whether you're trying to prevent it or trying to under active treatment, that you stay active to keep your bones healthy and keep yourself to maintain other cardiovascular health too. So it's always important.
Yeah, absolutely. Now you mentioned partner.
Yeah.
So let's take you to our next portion of this is that loved ones, people involved in your life, when they hear as well that someone has been diagnosed with prostate cancer, how best can a loved one support somebody that they care about so much after a diagnosis like this?
I think first, to emphasize the things in perspective about prostate cancer, is most part is indolent, not indolent, it's treatable. I think you need a conversation as to how planning the treatment, whether or not to proceed with it, and what type of treatment to proceed with, and know what the potential complications or side effects of some of those treatments are and how it would affect their relationship. And most of them, it's the erectile dysfunction that they key in on, but the incontinence part is also important because it's trying to keep healthy was clean, using sanitary napkins and those kind of things. So you know, it's important that the partners, of course, through the journey. It is a journey through the treatment, through the side effects, and maybe be part of the other aspect, you know, the healthy eating, making sure that they're active and both.
You know, it got me thinking that with the registration for today's STEGH talk, that perhaps somebody has just been diagnosed and they haven't told their loved ones yet, or they're struggling with what to say. Do you have any advice?
From the patient to the loved one?
Yes, from the patient to the loved one.
I think you have to start with the conversation that don't have the greatest of news, but again, to emphasize that this is a treatable disease, and I need you along with this journey. Together we can figure out how best to.
Well, thank you so much for all the insightful, all the insights you provided to us as a foundation, and as well to people who are watching. And we have, you know, it's not quite 2:30, but we do have quite a few questions. So if you don't mind, let's dive into those. So our first one is, and thank you so much. We appreciate all the questions coming through. Keep them coming. And if anything sparks more questions, please do put them in the chat. Is the cost of the PSA test covered by Ohip?
Okay.
If not, why not?
It is covered by Ohip, but there is a in the lab requisition, there's a line that says indicated or not indicated. If your practitioner or doctor picks off that it's not indicated, you'll end up paying for it. I always pick off. I always pick off indicated. So I always have a reason to check it. So every PSA that I ordered is covered. And why not is, again, there's this controversy about the PSA test not being completely diagnostic. It's not a yes and no answer. So there's so much gray area in terms of how whether or not it's helpful, and I guess they just don't want people to go and order a PSA for no reason. In my opinion, if there's a reason, it'll be covered. Anybody who's sent to me, I always find a reason.
Yeah, no, absolutely. That's fantastic, and that's why obviously you're so admired in the community. Okay, so the next one, what is the percentage of false positives in PSA testing?
The percentage of false positive, it also depends on age as well, but by and large, it's close to 80%. So, for example, the reason historically they use the PSA of 4 as the cutoff. Anything above 4, that there's a suspicion of prostate cancer. Anything below 4, there was less suspicion. But what we found is that if you biopsy everybody who has a PSA above 4, 80% don't have prostate cancer.
Wow.
20% will. And so that means what you're doing is you're in essence biopsying 5 people to find 1 person with prostate cancer, and that 1 person doesn't necessarily need any treatment either. And so the false positive is quite high. But the reason that they did that is that they noticed that people with prostate cancer, 90% of them will have PSAs above 4. And the caution here is that if 90% of people with prostate cancer have PSAs above 4, that means 10% of people with prostate cancer have PSAs below 4. So a normal PSA doesn't, a PSA below 4 does not necessarily mean don't have prostate cancer. Still, you have to weigh other risk factors. Family history, you have to have a rectal examination. Most PSAs below 4 that have prostate cancer, there's something done on that.
All good information for our viewers. Thanks again for keeping these questions coming. On to the next one. My dad is on hormone therapy for his aggressive prostate cancer. Can you please talk about this therapy and its possible side effects?
Yeah, when you get to hormonal therapy, it's aggressive, and this is what this is now palliative. You're not looking for a cure, and usually the cancer has spread to the bones or it has recurred after other curative treatment. So hormonal therapy is used because prostate cancer basically thrives in the presence of male hormone testosterone. So what you're trying to do is you're trying to prevent the production of testosterone and block whatever other testosterone that are circulating. You're trying to block its effect with other medications. So hormonal therapy is really androgen deprivation therapy. So androgen being the testosterone, and you're trying to deprive the body of producing and reacting to androgen, to testosterone. The problem with the side effects is that this androgen we need, males need testosterone. It gives you muscle strength, it gives you bone health, it gives you your libido. So the side effects from that are mostly hot flushes. It's almost like going through menopause, lack of desire for sex, and then weakens the bone. They can end up with fractures, very trivial falls can cause a fracture, and then dental caries or rotting tooth can also happen from that. So it's not a benign treatment. Having said that, being on vitamin D and calcium supplements are important, and also being physically active is also important to try to stave off those side effects.
Thank you, Dr. Cheng. Wow, you guys are really pouring in the questions. This is excellent. We'd love to get to all of them. We're going to do our best. Are there different types of prostate cancer? Fast moving, slow growing?
Yeah, that's what we talk about when we look at the Gleason score, and then we also look at in terms of pathology. You also look at whether or not it's gone into the lymph system. Whether it's gone into the vascular system. Like there are things, pathology indicators that tell us whether it's aggressive or not aggressive. Most prostate cancer is what's called adenocarcinoma, but and that's the most typical ones that respond to the hormones. But then there are other extremely, even in the adenocarcinoma, those are the ones that we grade from 2 to 10, 10 being very aggressive and 2 being the least aggressive. But we really don't see a grading of 2, 3, 4, or 5. Most grading are 6, 7, 8, 9, or 10, and 6 is what we would consider the low grade, less aggressive, not fast moving. 7 is an intermediate. 8, 9, and 10 are aggressive, fast moving ones. But then, besides the adenocarcinoma, which account for the majority, like 90% of prostate cancer, there are also sarcomas, urothelial cancer, and those tend to be very aggressive, and those tend to have more PSAs or low PSAs.
Okay, the next one. Are general incidence of prostate cancer on the rise? Perhaps if you could share some statistics, trends, anything you might be seeing?
Yeah, I don't have actual statistics, but we are, we're just seeing more because we have an aging population. People are living longer. We have more people, and so overall, not necessarily I don't think the incidence has changed, but the prevalence, the actual number of people that have prostate cancer is increasing, just by virtue of a larger population and aging population. I don't think the incidence has changed, but it's the prevalence, and then people are also more aware, so we're also picking up more.
Mm-hmm.
We have a lot of incidental prostate cancer.
Yeah, it seems like more people are doing these types of talks. People are, we're breaking down the stigma, that sort of thing.
But it's not just it's not just the ones that are being identified with the PSAs, but people are going for other scans for other diseases, and they're incidentally saying that there's something wrong with the prostate, or they're going for bowel issues and somebody does a rectal examination, so prostate feels abnormal. So we are, people are being assessed comprehensively, and so as a result, I think we're picking up more prostate cancer.
And I mean, that is a good thing.
Yeah, but again, not every one of those needs to be treated.
Sure.
Yeah.
Sure. Dr. Cheng, in your professional opinion, why are many men resistant to seeking an initial evaluation?
There's a emotional and a physical discomfort of having that kind of evaluation. The emotional one is don't want to. Most men are macho. We don't want to admit that we can have a disease, and we think that we're lesser if we go check for a disease that we don't even have symptoms for. And then for the ones that would consider it, knowing that you're going to get a rectal examination and be pulled for a blood test and possibly still sent for a biopsy, it's not something that is a very inviting or thing to look forward to.
What advice do you have for people who are a little bit timid, who are worried about that?
I think it's the same message as with the treatment. It's that know that it is picked up early. There's the option of monitoring or treating it actively, depending on what it is that you have control. When it's picked up early, you have a control as to how you want to manage it, rather than to have no options later on if it's picked up too late.
Other than cancer, what might other issues with the prostate be?
Prostate enlargement, prostate infection. The great majority of what I deal with prostate enlargement that causes urinary symptoms like frequent urination, difficulty emptying, people can't pee at all, or urinary retention. People with those symptoms need to be assessed as a prostate issue where they can't urinate at all, that can possibly go on to kidney failure. So they need to be assessed.
Yeah, very important to be assessed if that is the case. We are going to just again encourage you to send in your questions. It's all anonymous. We will not be using your names. And again, thank you so much for being here. We are going to post this to our YouTube channel. We still have 10 minutes left in this very informative chat. Dr. Cheng, I think I'd like to give the floor to you for a few minutes. Is there anything that we should have talked about that we haven't?
I think my concern is that people get too get in a sense that they get too obsessed with the actual PSA test, and they look at the number and the monitoring, the little changes in it. And to me, one of the more important things with the PSA when you get it, it's not, is it normal, is it not normal, is what the trend going forward. So I usually look for changes in PSA rather than the actual number itself.
So changes in the PSA
over time.
Over time. Okay.
A rapid rise is more. Somebody who has a low PSA that all of a sudden rises even a significant amount is more concerning than somebody who's got a high PSA that doesn't really change at all.
Okay. No, that's very good. Good takeaway. Another question just came in. Do you reach an age where an operation would be more dangerous than the actual disease?
Yeah, that's unfortunately one of those ageisms, or what we would consider age discrimination. And it may change over time. It has been 70. The age has been 70, where the cutoff is for radical prostatectomy for localized disease. That's because people think that beyond that you don't gain much in terms of added life overall survival, and the side effects of like erectile dysfunction, incontinence, and potential problems with clot in the leg and clot in the lungs that are kind of preclude that surgery. But certainly somebody who biologically is younger than they're 70 or 75 years old would still undergo surgery. Back in the days when I used to do the radical surgery, I've taken it out of a 73-year-old man and a 74-year-old man. So that biologically look younger and acted younger.
In that case, does it provide any more longevity to their life if that is the case in the early 70s, mid 70s, and they choose to do that?
Yeah, depends on their family history, right? Of longevity. You know, if somebody who's 70 years old, they like that, the family bikes off in their 70s from other illnesses, and they haven't done anything to mitigate their own risk. Not have to add much by trying to keep prostate out and trying to an extra 15 years.
Very, very excellent. Just information that our audience is able to take in today. And also, we have one more question. I think that we do have time to get to. Are there any activities that contribute to prostate cancer? For example, lack of or too much sexual activity? Is there an alternative? You know what? Like we said, we're pulling the Band-Aid off.
Yeah.
It is what it is.
Yeah.
You know, what
I think that's it's an old wives' tale. There's no such thing. And again, as I said, there is no activity or any diet that is prostate specific. It's just there's just a general health specific, like overall health problem, overall healthy lifestyle that you can engage in that would help mitigate your risk of cancer, prostate cancer, probably most other cancers and heart disease too.
Okay, and finally, is there an alternative or more reliable test than the PSA?
Yes, there are. There are other tests that we could do, but ultimately what that does, there's a PCR test. Sorry, there's MRIs that can be done, and then there's another blood test that can be done, called the PCA test. But the problem with some of those tests are, what they do is they kind of help us evaluate risk. That's what the PSA does. It helps us evaluate the risk. None of this is going to prevent you from getting a biopsy to make the diagnosis. None of these tests are diagnostic. No matter what, you need a biopsy to determine whether or not there's prostate cancer. So any blood test, any imaging test, all they're doing is just helping us identify what your risks are, so that we can make sure that we choose the right people for the biopsy, and then to biopsy the right places.
Well, we're almost at time. Very last question: what does a biopsy involve?
A biopsy involves removal of tissue from the prostate so that it can be examined under a microscope. And the most direct route to biopsying is through the rectum. So prior to the biopsy, you need to clear the rectum out with an enema. You need to start antibiotics so that you don't get an infection, or to decrease your risk of an infection. And then in the ultrasound department, one of the ultrasound doctors will put a probe, which is about the size of my thumb, up the rectum. And then they'll ultrasound the prostate and try and identify spots where they can put the needle in to get samples out of. If they don't see any worrisome areas, then they will systemically divide the prostate up into six sextants, and then take pieces from each one.
Dr. Cheng, finally, top 2 takeaways for people still with us.
Don't get too worked up over a PSA. There are treatments and options available to get that.
Wonderful having you. The community couldn't say enough about you when we started promoting this. Thank you so much for being here today.
It's been an honor. Thanks.
Well, thanks for everything that you do for our community. Just a reminder, again, we will have this live on our YouTube channel, STEGH Foundation's YouTube channel, in the next couple of days or so. Again, thank you to everybody who has purchased their Smile Cookie for our campaign this week. 100% of the proceeds purchased at all 7 locations in in St. Thomas at the Tim Hortons here come directly to the STEGH Foundation. That's going to fund top of the line ultrasound for our emergency department. So thank you for everyone who has bought a cookie. It runs until Sunday. Thank you again, Dr. Cheng, and wish you all the best and your patients all the best.
Thank you.